invitation, and thank you for joining us here on this symposium or the Awake Surgery. Thank you also for the introduction. And I would just share a few thoughts on the best practice recommendations, or how you can start off with Awake Surgery when you are in the beginning. Okay, so I think one of the most crucial things, and it has already been said before, is that you select an appropriate procedure for you to feel comfortable during the surgery and to start off with. And you need to select the right patient for this procedure and to have it in a good timing. And in the end, I will give you some further consideration, especially on the setup of the room. So, how can you maximize your own comfort level during this kind of surgery? Of course, it is very important to get some training. There is a learning curve. Dr. Welch mentioned 10 to 15 cases. I think depending on what you want to do, it can be a bit shorter or a bit longer, depending also on the experience you already have before. Then it is wise to take the patient first to the operating room, either making under general anesthesia or have it in the operating room under local anesthesia, because in the operating room you have a lot of resource. You have your anesthesiologist probably nearby, and if you have a problem, if you have bleeding, and if you need to react quickly, you can call for help, which would not be the case if you are doing this in the office, except you have an office which is inside the hospital, of course. And the last step would then be to go to your practice, to your office, and do the procedures there. Okay, what can you choose as procedures for awake surgery? So I think the most easy cases would be some balloon sinus dilations or the treatment of the ISIAN tube using the balloon dilations. Of course, you can also do some FES surgery, some initial FES surgery in your office, or if you have a revision case with a lot of polyps, you can try to remove the polyps inside your office. Then, as I said, the ISIAN tube dysfunction, the balloon which can be used for the sinus dilation can also be used for the ISIAN tube, and I think this is a quite straightforward procedure because you don't need to pass the middle turbinate, you don't need to pass the middle meatus, and you can go straight away in the inferior nasal portion and find the ostium of the ISIAN tube. Of course, the insertion of grommets is in this context important. And if you have nasal airway obstruction, so the reduction of the turbinates, or even a septoplasty can be an option that you can do under awake surgery. For chronic rhinitis, there is some cryotherapy devices available, which can also be used very well in your office. So, I think the key is that you select your patients in a good way. So of course you need to take a full medical history to assess the disease, and it's of course necessary not to take the patients with a very bad nose and a very advanced disease, but to choose patients which have mild or moderate diseases. And also a good risk analysis is important if you have patients which are very anxious, which are very nervous, who have psychiatric comorbidities. I had a case like that, but that's why I'm telling this here. And, or they have anticoagulation. Probably these are not good cases for you to treat in the office. So you will select the patients to whom you can talk to, because this is, I think, something very important during awake surgery. You need to have a patient who has confidence in you, and the psychology of your relationship with the patient is very, very important. So you need someone you can talk with, you can explain what you're doing, you can explain the benefits, and somebody who can communicate if the local anesthesia protocol is not working perfectly, where you should reposition a pledget, where you can, or if you can make a break, or so on. So this, I think, is really, really important, and I also sometimes do some cognitive exercises with the patients, try to find some strategies how to comfort them, how to make them quiet and easy so the procedure will go very smoothly. Of course, if you inspect the sinus and the patient does not tolerate endoscopy, probably this would not be a good patient as well. And then you can select your patient, which has a lot of confidence in you. You can select the patients which you feel confident to do the procedure under local anesthesia, and then go either to the OR or into your office to do so. Something important, I think, is also the positioning of the patient inside on either the chair or on the bed. So the supine positioning is quite important during the procedure. So if there is some blood, it collects in the epipharynx, and you can just remove it with a suction. During the local anesthesia, the pledgets, I think it's better to have the patient a bit inclined so that he or she is more comfortable. Okay, so there are some tools where you can find the right patients. Here we have the questionnaire for the second tube dysfunction, but I think this is more in general. I mean, if you would do this kind of surgery under general anesthesia, you also use the same tools, I think, for selecting the right patients. I would strongly advise to use questionnaires. They are validated tools and are very good also to control the findings or the results of your operation in the end. So we can, as was said by Peter Andrews before, it is important to find the patient, to take them away from the waiting list and to treat them even if the clinical priority, you can see here the ambulance is not very high in a general picture, but you can take them away from the waiting list and bring them back to your office and treat them as well, because it is very important that these patients get the treatment. There is a study investigating the difference between the chronic chest pain due to heart disease and chronic symptoms of a blocked nose, and actually most patients say that the rhinological symptoms would be more annoying than the heart ones, which is pretty surprising to me. So we can lower the cost because we need much less infrastructures, and then we can reduce the waiting time for our patients and therefore also their well-being. And of course, as it was said before, it is a cost-effective possibility to treat these patients. So here you can see a typical office, as you all know probably, and the important thing is that you have somebody to help you at least to set up everything and to help you during the procedure. You need to think about the equipment you want to use, which was pointed out just before. And of course, the chair needs to be very comfortable, or if you have a bed, I think it would be optimal if you have enough space in your office. It needs to be relaxing. As I said before, psychology is very, very important, and then you can start up with this kind of surgery. You need, of course, all the medications, but I will not go through this again. One important question would be the monitoring, if you need a monitor or not. Usually I think a pulse oximeter is a good thing, especially if you use diazepam as a premedication. In my opinion, if I have patients who are not premedicated, you can leave away this monitoring from your procedure. Then, of course, it is important to train your staff that they can handle the situation, that they can handle the equipment you are using, and also yourself, you need to be trained. It's very good to see somebody else doing it, to visit in a live setting, and in the end, be very comfortable on what you're doing. And to screen the patients, as I said before, it is very good to see how they react on nasal endoscopy using rigid endoscopes. And you can tell them that it is perhaps something similar like a dental procedure. And if they said that, well, this is it was horrible for them, then probably it's not a good patient to choose. And also, if you do the dilation of the sinus, you have to explain them before that they may hear some crackling sounds or something. I think the key is really to talk in a good way to your patient and explain everything so they are not surprised and they feel relaxed. So I will hand over now again to Andy Welsh for the summary.